When we look at social determinants of health, from my perspective, because I'm a First Nations person, it's just common sense.
Hello and welcome to Digital Health in Canada, the Digital Health Canada podcast. My name is Katie Brisky, and I am a podcaster turned digital health professional.
And I'm Sheila Maloney. I'm a digital health professional turned podcaster.
Now, there are many ways that we can think about health. It's multifaceted, multi-sectoral, and influenced by the social determinants of health. So what does it look like to care for the whole person? And what are different ways to be well? Today we speak with two leaders to explore how these factors shape health and wellness as individuals and communities. We are so honored to welcome to Digital Health in Canada, Pam Nolan, Executive Director, First Nations Digital Health Ontario, and Dr. Andrew Boozary, Executive Director at the Gattuso Centre for Social Medicine at UHN. Welcome both. Thank you so much for being here.
Thank you, Katie and Sheila, for having me. I hope I can be as exciting in providing information as you both seem to be by hosting this podcast.
Well, one of the things, Pam, that we like to host the podcast and bring people on who are leaders in their field and who are very interesting and have interesting stories. So on that note, let's get started. And maybe, Pam, we'll start with you. One of the things that we really like to give people an opportunity to introduce themselves, but we found that often people have a fairly circuitous route to where they are. So I'm wondering if you can maybe introduce yourself and tell us a little bit about FINDO, First Nations Digital Health Ontario, and how you got to be where you are in your position.
So, over the past 40 years, I was the health director in my First Nation community, Garden River First Nation, here in Ontario. And during that time, I started to get interested in digital health, maybe in the early 90s. And there were few people, let alone First Nations, using any digital tools at that time. So as my interest grew, I found it more challenging to find any support or help from any level of government, whether that be the federal government or the provincial government. Digital health didn't seem to be on anyone's radar. So with some local support through various health organizations within the city of Sault Ste. Marie, we launched our first EMR. That was in the 90s. Shortly after that, I guess because of that work, I was recruited to be a member of the Chiefs of Ontario Panorama Working Group. Everybody knows Panorama, the immunization repository, and they were looking to see how First Nations could and participate with Panorama. And as I met other health leads from across the province who were also on this working group, and as we began our discussions, it wasn't just about immunization, it was about digital health for everything else. EMR support and sharing information with the province and our home and community care, getting good information, especially for discharge planning. So we put our heads together and said, you know what? Nobody's out there helping these First Nations. So let's go to the Chiefs in Assembly, Chiefs of Ontario, and find a couple of chiefs who think we have a great idea here. And we did. We were successful. We had the chief from Nipissing First Nation and the chief from Garden River First Nation support this resolution, and they took it to Chiefs in Assembly. And the resolution called on is to support a digital organization that would support First Nations right across Ontario. And that resolution was unanimously supported by the Chiefs in Assembly. And here we are today. FINDO was incorporated just before COVID, so in 2019. So that's the story, and that's my story. Thank you.
And thank you for sharing that story with us. It's really good to have you, and I'm excited to get into more of your work and more of the work that FINDO does. As we continue our introductions, though, Andrew, can I pass the mic over to you?
Yeah, thanks, Katie. In terms of the journey, I think it's one that's obviously, I think, continuing to be shaped by everything that's happening, of course, around us. But, I would have to say for me, so much of this, as we go back to the roots or the rationale for why we're engaged in the work, which we are, and for me as a frontline primary care doctor, really at the intersection of health inequities and social justice and healthcare performance around improving the quality of healthcare systems for people who have been marginalized. So much, sure, all of it really starts with my mother, and I think so much of that from where we grew up in the early days of St. Jamestown, which is one of the most diverse square kilometers in Canada and in downtown Toronto. But as my family had some really lucky breaks, which were not as available to people that we live with in the same apartment building, in the same floor, it was really clear early that this is not about individual failures when it comes to being able to deliver on health and well-being or attain the sort of health and well-being people want. So much of this was tied to policy decisions. And so a lot of my work has really been both at frontline care delivery, about trying to address untreated diabetes, to how we manage different chronic disease, to really also the larger structural issues that discriminate against marginalized communities and drive worse health outcomes when it comes to lack of housing access. All of the real sort of policy considerations that have seen this come together with health and social policy, I would argue, being health policy writ large. And so that's where I've been really fortunate, from early teachings of my mom to so many mentors and colleagues and friends that continue to help teach me and guide me in the work, as there is no shortage of challenges and these compounding crises that so many are engaged in fighting up against.
Thank you, Andrew. That was interesting to hear your journey. And I think one of the things that you're emphasizing is not just dealing with individuals and prescribing medicines as a primary care physician, but that real emphasis on policy, advocacy for policy change and policy review. Are there any specific examples that you have, or something that you're especially proud of in your work that has made a significant difference that you would like to share with us?
It's tough because I think with the question about proud or having pride, I mean, the challenge, I think there's really not much time for reflection on that, or even that kind of sense when you really feel in the work that so many are drowning in these inequities, and I think you can look at these pockets of success for sure. And I think the one that probably is just most top of mind for me is the housing initiative that we have, the social medicine housing initiative, which will be lifted up in the coming weeks. And when we look at the work, it's a partnership with the City of Toronto, the United Way, and Fred Victor, a supportive housing agency and shelter support agency, to house 51 individuals that are actively unhoused, that have been homeless actively for quite some time. And I think, the reality that 51 housing units is not going to end a homelessness crisis, where we have over 10,000 people without housing or an 8 to 10 year wait period. But so much of the learning about what this means for people individually. And what I think is different about this is people get permanent housing. We have a lease just like you or me. And this is not a hospital discharge exercise. This is truly about people having housing. I hear so much from my patients about the excitement about people wanting to be able to cook their own meals. And part of this drive, where there's been a great push from the University Health Network to leverage the resources and land for affordable and deeply affordable housing, is that for many of these patients, they ended up in the emergency department because there's nowhere else to go. And we had some early data numbers that 234 patients made up over 15,000 ED visits or emergency department visits in just 1 year. The most recent data is that we have over 100 patients accounted for close to 4,500 emergency department visits. And for some of them, it was just, there was nowhere else to be. There's nowhere else to sleep. There's nowhere else to get care and attention, with the shelter bed capacity being where it's at. But for many, it's also that disease conditions that could have been better treated were not, and that they are having more complex chronic disease issues that we have allowed to take place through this active policy decision of accepting that thousands of people to tens of thousands of people across the country do not have housing. And so this was a real effort with strong guidance and learning from a lived experience advisory council to people who've experienced homelessness to community leadership that's been pushing and advocating for access to housing for quite some time that are starting to finally move people into place this October. And I think that's something where it's been a learning, that's been an advocacy issue, rightful issue for as housing as a human right for decades. But to see it now into practice and see something concrete with the sort of health and social supports people need to thrive, something we continue to try to draw some hope and meaning for, given how outsized this problem is across the country.
As you said, those 51 people will absolutely change their lives. Pam, now let's talk to you about that in terms of specific initiatives. Or have you seen the services that you provide change over time? Are there things that you're especially pleased to have been able to put into place?
I think what I'm most pleased about is that we were able to put an organization in place that would really work towards directly working with all the First Nations across Ontario to understand their digital health needs. We, so naively thought that that was the important place to start. And I think what we found out pretty quickly was that a lot of First Nations didn't know what they didn't know. I know that's kind of a cliche term, but really, when you don't even know that there are provincial tools out there to connect to, when you don't even know that they exist, you're not going to know that you're missing anything, right? So going right back to the basics and working with First Nations to help them understand how digital health can improve a person's life in their community, I think was really important, or really, something that it was just like an aha moment. Wow, this is going to make a huge difference because we are now able to get out there and let people know what's available. I say that optimistically because there's a lot of work to be done for First Nation communities who are basically just using the providers in those communities using fax machines still, and they're still charting on paper. There's a long way to go. There's a long way to go, but very pleased now that we can help them move forward. So we often meet with the province now, and the province who've invested significantly in digital health to say, you know what, somehow we were overlooked all those years. We were passed over. People think they're working with First Nations when they work with provincially funded organizations like Aboriginal Health Access Centers or family health teams that are funded by the province, but those aren't the same health teams that we work with. We work with on-the-ground health teams that are more or less funded by the federal government. So that was a real challenge, and I think I'm pleased, again, to be able to provide the provincial government with a better understanding of who First Nation health teams are and who they are not. So, you're missing a whole group of people there that have been overlooked for years. So, all those investments in digital health, like I said before, First Nations were not included in those. I don't know why. I think it was just a misunderstanding maybe. But you have thousands of people out there who could really benefit from some investment from the provincial side in digital health. I always say, we can't keep up until we can catch up.
That's a really impactful way to put it. I think it's another great example of how that work on the ground can make such an impact for people in communities. And Pam, I wonder if we can go a little bit deeper into some of the work that you do with communities. Because I know with Findo, you work with communities, you really work to understand their unique contexts and their priorities and their challenges. And so I'm wondering if you can walk us through that process a little bit.
So like I said, First Nations are spread right across Ontario. So some are southern and some are very northerly. They all have different needs, very, very complex service models. You can't paint them with the same brush. Not one community is the same. You have to understand their political structure, which PTO, political treaty organization in Ontario they're tied to. Are they getting funding from the federal government? How is that funding arrangement? Are you hiring your own nurses? If that's not possible, the federal nurses coming in to provide that support, yes or no? Do you have any provincial services, provincially funded services at all? Are your services coming from a group, a collection of First Nations who band together to form maybe a different health team group that supports those First Nations? So once you get an understanding of that kind of landscape, first of all, then you can start doing a deeper dive into asking those questions about what does your nursing workflows look like? How do you do things right now? Where do you chart the information? Where do your clients come? Do they use virtual care services? So multitude of questions just to get an understanding from the community of what they're doing. And then once you get that good understanding, you need to really start looking at, there are some requirements on the provincial side to connect to some of these resources. You have to have really good privacy and security policies. You may have to have some IT support. What about the connectivity? What are the issues here? What do those look like? It's not easy, but you need to take all those things into consideration. And we really, really stress that we need to start where the community is at. And if there are changes, related to turnover in those communities, okay, let's start from square one again. Let's just go right back to the beginning because the person, we were working with before, the nurse, is no longer there. She's moved on. So we have to start again. I think it's important also to note in all of the First Nations that we work in, there are no real IT support people in most of those First Nations. Those are outsourced, maybe provided by, an external service provider, and that can only get into the community whenever they can get there. There's sometimes no real connectivity, or sometimes people say, oh, there is connectivity in the community, but guess what? It's only going to the nursing station. It's not gone to the health center, 2 different places in the community, right? Or it's only at the band office. Or the nursing station is sharing that with community members that stand outside their door trying to get access to the internet. So a lot of interesting scenarios that are happening in some of these communities. I mean, I'm not just talking about the north because there's connectivity issues in the south too. You're probably aware. Sometimes in, different places, maybe that you were, even in the city, you wouldn't get good connectivity.
It really strikes me, I've talked in digital health conversations before about really thinking about the whole person and meeting the person where they're at. And it's so interesting to hear it about thinking about the whole community and meeting the community where the community is at. And Dr. Boozary, it sounds like there's a similar, perhaps, lens in the work that you do with the Social Medicine Center.
Yeah. I mean, there's so much learning from Indigenous colleagues and elders, and so much of the work that I think Pam has laid out so powerfully. Really, I think when we talk about the definition of social medicine, it is about trying to get at these roots of inequality, of injustice that drive poor health outcomes. And I think it's very alarming at times for people who think, well, we have a universal healthcare system in Canada, so we have pretty good health outcomes. And when you actually compare us to other OECD countries, we don't do that well. And a lot of that is there are major access issues where there's been tremendous research led by Indigenous researchers and organizations showing long-standing gaps in access to surgical services, to medical services over many decades. We're seeing this with refugee newcomer populations the last 20 to 30 years. Tremendous work by Black-led organizations and researchers through the pandemic, especially showing these very serious gaps in access to life-saving interventions. And so much of that advocacy and work really shifted certain public health authorities to say, we're going to collect race-based data and sociodemographic data. It's really underpinnings of any social medicine work. When we look at the histories of social medicine, I think one of the telling quotes is about that really that this medicine is about policy decisions on a grand scale. And when you look at some of the other work that's been done around how can we better help prevent poor outcomes by the sort of partnerships, and to me, it's not as much about social prescribing, but the power of partnerships with various organizations and expertise people have in terms of where we need to be thinking about differently as healthcare institutions and hospital networks, where we've had, I would argue, more of a rigid view and this sort of unilateral perspective of where innovation moves in and out of the hospital into communities, and really this delivery gap and this failure to embrace the innovations and how to better deliver healthcare, I think has held us back and is another driver as to why we have far worse health outcomes than some other jurisdictions.
It's interesting you talk about that. There's the dichotomy, and I want to talk to you about this a little bit, that you work for University Health Network, I think the biggest, largest network of hospitals in the country. And some might think it's innovative, it's leading edge, it's using all the technology. And for the University Health Network and other facilities like it across the country to establish a social medicine center, to bring somebody like you on staff, to take parts of their budget to buy and build affordable housing, that's a major shift. How did that come about? You gave the stats around small numbers of people using a lot of the emergency services. Was it a budgetary decision? How did the whole conversation come about?
Thanks, Sheila. I think it's really important to reiterate your point that a lot of what we're doing is in no way altogether new, right? Community health centers have been pushing and driving so much of this work for decades. It goes all the way back to the Hastings report. We've seen this in the Lalonde report in Canada that's now 50 years old. Again, and I think for decades and centuries, from Indigenous leadership and wisdom around how to be thinking more broadly about these notions of health. And we have taken, in many ways, for a number of years, an acute care perspective. What does the utilization look like? What is more or less utilization good or bad? But really, I think, hearing so much of Pam's work and being able to engage with more folks across the country, what does health and well-being mean for people? And one of the things that was great to see the University Health Network really step forward in this space is the question or the challenge: are we the University Healthcare Network or the University Health Network? There's a fundamental difference between health and healthcare. And if you're the health network, there is a large body of evidence and work about what actually drives and determines better health outcomes. And so I think that was part of the push, Sheila, around thinking of what is the lane in housing, or housing as healthcare, housing as a health intervention. What does it mean when it comes to food insecurity, or partnering with public health and community health centers in rolling out vaccines that play a crucial part in terms of trying to mitigate some of the disparities? What does it mean in accessing primary care to addictions and harm reduction services that really pivotal in keeping people alive? So that, I think, is the fundamental shift. I think the data tells a really important story, but I think the big part of it is, what is the narrative arc? And I think it is around, as you've mentioned, and of course is clear here, that this, as the largest academic health sciences network, this is evidence-informed treatment. These are evidence-informed pathways, and we can't see these clinical divides and silos that have been shutting people out of innovation, of life-saving treatment, of progress. And more than that, I would say, it's having lived experience advise and guide and set what more and more of the priorities are for us as the Gattuso Center for Social Medicine. And so that, I think, is where we're trying to go. Of course, this is always a work in progress. There is no, I would say, finish line when we look at the outcomes we want to achieve. And given how dire many of the outcomes are, we continue to lose people every day who cannot access housing or are drowning in the pathologies of poverty. And so I think that is really where we're trying to see some of the shift. And I think the data has been helpful to try to push those conversations both internally and externally with our partners. But really this fundamental rethink around what is the role of the hospital as an anchor institution in communities that have some of the largest footprint when it comes to hiring practices, to environmental and climate change policy, to what's available by the way of procurement, and food insecurity, and housing policy. So that's really the hope and the push. And I think, again, I continue to learn so much in this role as now coming into 5 years in the coming months. It was a pressure cooker through COVID of where, it made the work in many ways more important than ever. But what I try to draw some hope from is that it illuminated the social determinants of health in a way that was not breaking through to people. And my only hope in this work is that those lives that we lost, the lives we lost before the pandemic, the lives that we continue to lose are not in vain, and that we are actually serious about prevention and that we are serious about social medicine as a society.
That distinction between health and healthcare is really powerful. And Pam, I'd be interested to hear your perspective on this, as I know FINDO also is involved in the Indigenous Digital Health Ecosystem, which is an integrated suite of platforms that don't just address health, but also domains like education and housing. What is your perspective and your experience in terms of social determinants, health, and healthcare?
I think when we look at social determinants of health, from my perspective, because I'm a First Nations person, it's just common sense. There's no other way to look at it. We were always in our teachings, if the individual is healthy, then the family is healthy, extended family is healthy, the community is healthy, and it just keeps building from there. So when we were asked to become part of the IDHEs, the work around identifying digital tools to capture determinants of health, really related information and material from First Nations, from that perspective of a healthy person. And it just made sense. It was just something that, why didn't this happen years ago? Or, I say this not in a bad way, but I remember in my work as health director in the early days, we had all the services under one roof, basically for health. So mental health and addictions was under one roof, home and community care, patient transportation, maternal child health. Because my community was 1,500 people, on reserve, and we had one health center, it wasn't an odd concept for me to integrate that healthcare. So that come very naturally to me. As I started to reach out back in the 90s to my colleagues in the city, I really got to see how the healthcare system outside of my community was really fragmented. Home and community care was like up on the hill, and the public health unit was way over here, and the other services across, mental health and addiction were like, 2 miles away from those other buildings. And it's like, wow, they could really learn something from First Nation healthcare. And that was way back when. So I think people are really starting to see the benefits of trying to make sure that information on a person is available no matter who that health information comes from, but that's available so that we could start taking care of the needs of the whole person. And the IDHE project is even going beyond that. We're not only talking about those, health things, we're also talking about, Jordan's principle, the information from that, the information from education, the information from housing, all of those pieces that if they, had using digital tools in the First Nation communities to start collecting, the person would be the client for all of those different purposes, right? And thinking about this maybe as a digital case manager, that's how I always think about the IDHE project. So it was a case manager, a care manager that had the capacity digitally, all that information would come into one system. There'd be all kinds of permissions and rights and consent and all those things taken care of in the background. But wouldn't that be wonderful for this case manager to be able to say for this client, you know what? There's an issue here around housing that I think the housing people need to really start addressing. And or when the housing person was, doing their housing, they've noticed that one of the children had, could benefit from some sort of special needs device or something. And maybe, that case manager, through the digital case manager, would be able to notify Jordan's principal. So it'd be really the way that I think that the IDHE project is going is really incorporating how First Nations really think about determinants of health and using digital tools to make sure that we're using all that information that's available out there right now in a good way to support that client, because that's what it's all about at the end of the day. In all the diagrams that we do, we put that little client in the middle, that little person in the middle, and I see that little person there. And that's what drives me to do what I do today, just to make sure that person has the best care possible and their needs are met in the best way possible.
One of the things that you both talked about is information and data. And, Andrew, you talked about evidence-based and using the data to drive these policy changes and make people aware of some of the issues. And Pam, you talked about, your digital case manager having all the information about the whole person together in one spot. You also talked about power of partnerships. Both of you talked about the acute care sector, the community, and all the people involved coming together. I want to tie that up a little bit. Maybe, Andrew, we'll start with you around how has digital health impacted the work that you do in some of the things that you're doing around your social medicine initiatives?
Firstly, I think Pam's example of the digital case manager is so inspiring. I think that is really where we would want to go, I think where the system needs to go in terms of the kind of community health worker, case manager approach where technology is helping enable both the practitioner and the patient or client. And I think how can that be continued to be technology used as a tool to mitigate disparities as opposed to widen some of the inequities. And I think if there's real active thinking and implementation of how technology and digital tools are leveraged to actually bridge those disparities, I think there's a lot of promise in that. And a lot of the time it's from folks that I've worked with who are far more versed in the digital health space than myself, and listening to Pam's expertise. I mean, really, I think it's about how do you incorporate or better integrate the human element that technology and digital tools allow to take place, whether that's in a patient interaction, whether that's in the sort of follow-up, or as Pam mentioned, identifying what the needs are either under one roof or out in community, whether that's from various obstructions to accessing care or obstacles to accessing care to housing policy. that's to me where a lot of this work is really exciting. And I think there are so many leading examples like under Pam's leadership. So I think that's something where we are not fully in the digital health space at the Gattuso Center for Social Medicine. We obviously see the real importance of this given where all of these conversations are going. And our real drive in it is how can we help partner with digital health experts in bridging and prioritizing patient populations that have historically been an afterthought, if anything, about some of these innovations. And then we're all supposed to feel some sort of surprise as to why the inequities are only widening. Again, was very stark during the early days of COVID. And there was huge and pivotal community leadership to try to bridge those disparities throughout neighborhoods and really understanding that postal codes were really a proxy for poverty and for the social determinants of health. It's not something that's inherent in the geography. And I mean, I think Pam's wisdom on how obvious and central the thinking around the social determinants of health is. You know, I really don't like the term social determinants of health, and we use it all the time. I find it very academic and in some ways this sense that these things are predetermined or that these things are looked at as deterministic or there's some sort of law. I mean, these are human choices vis-a-vis policy. And it's something that, you know, is so obvious to us even as children. And I'll close with the story around talking about where I grew up in St. Jamestown. We were right across the street from Rosedale. So I think if folks are not from Toronto, Rosedale is this beautiful, affluent, leafy, it's often referred to as leafy Rosedale because there's just so much green space. And less than a block across the street is St. Jamestown, where there is a bunch of high apartment buildings, a lot of social housing, Toronto community housing, but a total paucity of green space. And there's been really important research from colleagues looking at the fact that access to green space is a really good predictor of whether people will develop diabetes or not, because you can go out in nature, you can walk. And when you're a kid looking out across the balcony, you think it's like a different universe. You think it's like Narnia. And you realize that the opportunities and to live a healthy life are no equal. And this has nothing to do with geography because you could throw your stuffed toy across the balcony into Rosedale. And I think that played out, through COVID, where we saw 3-4 differences across of COVID rates by one block. We continue to see those same rates around cardiovascular disease, diabetes, cancer rates. And so I think these are things that we feel and know what the social determinants of health are as children, but where we've kind of resigned to some belief that there's this hold that the policies can have or this failure as individuals for not being quote unquote healthy enough. And that's what I hope these conversations can help push against. And it's always so inspiring to see the work that's happening in the digital health space led by Pam and others to really try to push back on those notions in really pragmatic and concrete ways.
He just nailed it. When you look at the determinants of health, like social determinants of health, or some people have dropped social and they just start using determinants of health now. And for me, I think it's finding the right people to talk to that can make this change. Finding the right people at the federal government or the provincial government. All I've been hearing for years and years and years really is reasons about why we can't do something, right? Oh, there's a policy around that, or there's this act that doesn't permit that, or there's always an excuse for why you can't do something. So I'm pushing people when I go to these meetings or when I get the opportunity, I say, you know what, quit telling me why we can't. I'm tired of hearing that. I've been hearing that for 40 years now as health director and nothing has changed. Tell me how we can. There's got to be a way, whether it means that we have to go and lobby some minister or get on some committee or change some wording in some act or add some wording to maybe PHIPA or modernize some of these old standards or whatever it might be. Tell us how we can do it because we're prepared as First Nation communities, as a First Nation organization, to start doing the work now, the real work. We want to see that change. We want to make that change. So determinants of health, to me, is only going to be successful if we all understand what we're talking about. Determinants of health might mean something completely different to you. It might mean something completely different to somebody at the Ministry of Health, or we all have to get on the same page, so we all have to say the same vision. For example, you can talk to me about determinants of health today, and I'm passionate about determinants of health. That's how I grew up. That's how I lived. That's kind of what I believe in, right? That ingrained in me. It just wasn't a term that I looked up in a book and, tried to figure out what that meant. It can be a really powerful thing if we all look at it in the same way and say, this is what determinants of health means. And if we all work towards that, oh my goodness, we're going to be able to change lives. We're going to be able to change the future. But if it's just words on a paper, we're going to be back here again in another 20, 30 years saying, oh, what's determinants of health mean to you?
That's a great ending and a great common last word, Pam, in terms of let's just understand it and let's just do it. And let's all work together toward that same vision. Thank you so much to both you and Andrew for speaking with us today on this very, very important topic. And congratulations and thank you for all the work that you do in this space. Wow, what a great conversation. People that are making such a difference in the world. It was just, what are your key takeaways?
I think both our guests really challenged us to think about what we mean when we say determinants of health, right? I think both in terms of looking at the social determinants of health as not being deterministic, and also that need to articulate a common vision of what we mean when we say determinants of health, because it made me wonder if sometimes when we look at these inequities and disparities in health outcomes, if just saying, social determinants of health can sometimes be a bit of a way to elide the policy choices and the choices that collectively many of us have made that have contributed to these inequities and these disparities. And so I think it makes for a more complex situation, but it also, if they are choices that we have made through policy or otherwise, they're choices that we can change. And I think that that's very empowering. How about you, Sheila?
My favorite line in the whole podcast came from Pam. And she said, it's just common sense. Somebody who is healthy is somebody who is safe, who has food to eat and a house to live in. It's almost this artificial health versus healthcare. But the thing that I liked best about this is just hearing about the initiatives, and in particular, what Dr. Boozary was saying about organizations like the University Health Network, who are really making an effort and have strong voices and can influence this policy direction, and taking cues from the Indigenous communities and taking lessons from the communities and talking about the power of partnerships in making these changes, and the power of working with people with lived experience and making sure that they are driving the change. And so that was a really, I like, it's just common sense, and we just need to do it.
Something else I really appreciated was Pam's description of in every diagram, no matter how complex these health systems get, and they can be incredibly complex, especially looking to Indigenous health, in the center, there's always the person. That's why we do the work that we do. And it kind of reminds me of the conversation that we had in our last episode with Tracy MacArthur and Victoria Lee of knowing yourself and knowing your purpose and knowing why you do what you do. And I just see that so clearly in both of our guests today. They know why they do the work they do. They know why they're here. And I think that that's a good reminder for all of us to really think about what is it that drives us? What gets me out of bed on a Monday morning to bounce into work?
Well, and and patient-centered care has been a term that we've been using for a long time. And I think, people like Pam and Andrew are living and breathing and truly are committed and believing this patient-centered care. It's not a term. It's not a phrase that we use. It's purposely thinking about this is the person about whom we care and we are going to ensure are healthy and not just has access to healthcare resources. And so, yeah, it really drives home the meaning of patient-centered care.
I mean, I think we could talk about this for another hour at least. But as we come to a close, listeners, we'd like to thank you so much for joining us today. If you are looking for more digital health content before our next episode, remember that Digital Health Canada members can register for Webinar Wednesdays on the Digital Health Canada website. As for us, we will see you next month, right here on Digital Health in Canada, the Digital Health Canada podcast. Thank you for listening to today's episode. Digital Health Canada members can continue the conversation online in the Community Hub. Visit digitalhealthcanada.com to learn more. Be sure to subscribe to the podcast to get new episodes as soon as they're available. And tell a friend if you like the show. We'll see you next month. Stay connected, get inspired, and be empowered.